Good evening, everyone. This is Steve. In this video, we're going to be doing a brief topic review on toxic alcohols, covering methanol, ethylene glycol, and isopropanol. We're going to be discussing common sources, pathophysiology, clinical signs and symptoms, lab investigations, and other diagnostic pearls, as well as approach to management. So to begin, methanol is found in a number of things, including windshield washer fluid, gasline antifreeze, paint thinners, lacquer thinners, and bombing fluid. You can also find ethylene glycol in windshield washer fluid. Some windshield washer fluid contains methanol, some ethylene glycol, some combination of both. You can also find ethylene glycol in antifreeze, but note here is usually radiator antifreeze or engine antifreeze, whereas methanol is found in gasline antifreeze. Isopropanol are found over the counter in the rubbing alcohol, hand sanitizers, antiseptic preparations. The thing that makes methanol and ethylene glycol, especially these two, rather than isopropanol, toxic is because of the toxic metabolites that's produced. Let's go over to take a look at the metabolism of these things. So, in comparison to ethanol, which is up here, methanol and ethylene glycol are metabolized by the same enzyme, alcohol dehydrogenase and aldehyde dehydrogenase, as ethanol. But ethanol is first metabolized into aldehyde dehydrogenase, by alcohol dehydrogenase into acetaldehyde, and then aldehyde dehydrogenase into acetate. And this acetate is made into acetyl-CoA and is used in your intrinsic metabolism tricarboxylic acid cycle, and then can be made into amino acids or fatty acids. So this is used, and it does not produce toxicity as much. Whereas methanol, it's first metabolized into formaldehyde and then metabolized into formic acid. Formic acid is not able to be incorporated into our intrinsic metabolism and is quite toxic. So it acts as a mitochondrial toxin, inhibits cytochrome oxidase in the oxidative phosphorylation, the electron transport chain, and it's especially toxic to the brain tissue in the area of retina and optic nerve, causing ocular toxicity. You can get symptoms like snowstorm vision, scotoma, blindness. It can also be toxic in the basal ganglia of the brain, especially putamen, causing clinical features similar to Parkinsonism. And you can find this on CT scan sometimes in the severe cases where you get basal ganglia necrosis or putamen necrosis and hemorrhage. So that's formic acid. That's the toxic metabolite. For ethylene glycol, it's also metabolized by alcohol dehydrogenase into glycolaldehyde, and then that is metabolized by aldehyde dehydrogenase into glycolic acid. So glycolic acid is the main contributor for metabolic acidosis. And glycolic acid is further metabolized into glycoxalic acid and then oxalic acid. So oxalic acid is another major toxic metabolite here. It can bind with calcium and and then oxalate is a 2 minus. When you get rid of these hydrogens, you have 2 minus, so it binds to calcium and forms calcium oxalate crystals. And these deposit in their kidneys and causing acute tuberous necrosis, AKI. Can also cause hypocalcemia. It can cause also neurotoxicity when it deposits in your brain. It can cause cranial nerve deficits in the severe cases, and cerebral edema. Isopropanol, because the hydroxyl group is attached to the carbon in the middle here rather than at the end, it can only be metabolized one step further by alcohol dehydrogenase into a ketone group here. And because it's not at the end, it cannot be further metabolized into an acid. So isopropanol does not give you acidosis. So this is your classic ketosis without acidosis. Isopropanol, the parent compound itself, give you local irritation of the stomach. Can cause hemorrhagic gastritis. Okay. So now we've covered the signs and symptoms of methanol, ethylene glycol, and isopropanol. By the way, inebriation can occur in any alcohol, but the larger the size of the molecule, the more inebriation per amount. So isopropanol, in equivalent amount, you will have most inebriation, followed by ethylene glycol, followed by ethanol, followed by methanol, and they can also give you they can all give you that. In terms of lab investigations, so when a patient present with toxic alcohol, they, depending on when they've come in, so this is a classic graph where you have, this is your time, this is time 0 of ingestion. In the early on, the methanol, ethylene glycol, the hydroxyl group, the alcohols are not metabolized yet. They contribute to a high osmolar gap, but does not produce a lot of toxic metabolite, so it does yet. So it's not. So the patient doesn't have metabolic acidosis. But over time, as the alcohol is metabolized into acid, it produces a metabolic anion gap and metabolic acidosis, and the osmolar gap drops because you're metabolizing the parent compound. So you can actually have a normal osmolar gap, but elevated anion gap when it's very late. Most patients present somewhere here, so you have both a high anion gap and high osmolar gap picture. So high double gap, that's one of the features of toxic alcohol. And in terms of things to look out for on history, so of course exposure is important. When you have a history of ingestion, or like a kid comes in, they were licking a bottle containing antifreeze, you know to take that seriously, and that's an important clue. If you don't have a history of exposure, and you just got a patient that has can be intoxicated, if they have any vision changes, that's a red flag to think about methanol. So for physical exam, if they're coming in really early, they may not have any sort of metabolic acidosis. They're just inebriated. But as time goes on, if they present delayed, they will have this metabolic acidosis, which will give them a picture that looks very similar to DKA, where you get Kussmaul breathing, where the patient is trying to compensate by breathing off the CO2. So really look out for patients that have tachypnea, Kussmaul breathing pattern that doesn't have DKA. So that's a clue that there is a significant metabolic acidosis going on, and toxic alcohol should be on your mind when you see this. And when you think about investigations, we talk about elevated anion gap, elevated osmolar gap. Those are concerning features. Urinalysis, you can find oxalate, calcium oxalate crystals. If you are that may give you a clue as ethylene glycol ingestion. If they are very obtunded, you get a CT head, you get putamen, basal ganglia, necrosis. Think methanol. Otherwise, blood gas. You can get elevated lactate, especially in ethylene glycol. You can get a very high lactate, and this is a false elevation of lactate, because if you get a serum lactate, it will be lower, so you get a lactate gap. And the reason why is because on some of the blood gas machines, you can mistake ethylene glycol, which if you take a look at the ethylene glycol's metabolite, glycolic acid. This is glycolic acid, and if you add a carbon here, that's lactate. So some of these blood machines, their electrodes can misidentify glycolic acid as lactate. So that's the only difference here, so that they can mistaken glycolic acid to lactate. So you get a high lactate on the blood gas machine, but your serum lactate, which measures the true lactate, is much lower. That's another clue. You can have low calcium, so you can get the calcium on the blood gas, and ethylene glycol can bind the calcium, give you hypocalcemia, and this can sometimes predispose you to lung QT and torsade. And in terms of isopropanol, the classic picture is acetone, very severe inebriation without ethanol, and then they have a positive ketone but not acidotic, and that ketone is from the acetone. And oftentimes these picture patients will have a chronic history of abusing rubbing alcohol. Alright, so that's lab testing. In addition to the ones we mentioned, getting CBC, lyse, creatinine, glucose, urea, so this allows you to calculate the anion gap, osmolar gap, blood gas, ethanol concentration is important. So when you see a patient with elevated anion gap, elevated osmolar gap, but ethanol is also elevated, it's unlikely that the patient have toxic alcohol ingestion, because ethanol itself is a alcohol dehydrogenase inhibitor. So if you co-ingest ethanol with methanol, for example, you will block the metabolism of the parent compound, and that shouldn't give you toxicity, unless you drank methanol and then you metabolize some and later you drank some ethanol. So that'd be a rare clinical scenario. So in this case, really think about alcoholic ketoacidosis. That's one of the diagnoses that is commonly not thought of, but very, very common actually when we get called a PADIS, that it's is a query methanol ethylene glycol ingestion, but it's really is alcoholic ketoacidosis. So if the ethanol level is elevated, even though the patient has maybe a high lactate, high NN-GAP, they may not be, it's less likely to be toxic alcohol. Another thing I wanted to just quickly review is how to calculate NN-GAP and osmolar gap. So NN-GAP, remember, sodium minus your chloride minus your bicarb. Osmolar gap is your measured osmolarity minus your calculated. So calculated osmol is your 2 sodium, sugar, and a bun, urea, and also we take account of ethanol. So if you have ethanol on board, you times that by 1.25. That gives you a osmolar gap. So if it's greater than 10, that's considered abnormal. NN-GAP is normal is 12 to 16. So if it's elevated, can above 16, that's considered abnormal. Other labs you can order for methanol, ethylene glycol, isopropyl alcohol is your toxic alcohol panel, which has a turnaround time about 3 hours. Faster if you're at the foothills because the lab is done at the foothills, slower at other sites. For methanol, if the patient is very sick, CT scan, as we mentioned, can give you these features of cutaneous necrosis, basal ganglia, hemorrhage. Ethylene glycol, you can get additional lactate, serum lactate, to get the lactate gap. Your urine can give you oxalate crystal, calcium oxalate crystals. Isopropanol, doing a ketone, will show ketosis without acidosis. And of course, you also want to be ruling out other co-ingestions, so your standard, make sure that they don't have ASA or acetaminophen on board. All right, so lastly, let's talk about treatment. So treating toxic alcohol is really, there's a few key steps. So number 1 is your aldehyde dehydrogenase inhibitor. Number 2 is your bicarb. Number 3, dialysis. Number 4 is your cofactors. So only a few things. Of course, when we think about sick patients, we always do first ABC, D, E, F, G approach. So resuscitate if they're really sick, fluid if they're hypotensive, decontamination, D stands for decontamination. So alcohols are absorbed very rapidly, so this doesn't have a role here, so you wouldn't be doing charcoal or whole bowel irrigation. E is elimination, so here your hemodialysis, maybe urinary alkalization, but it's the bicarb is more for not for ion trapping, to prevent the non-ionized the non-ionized formic acid from entering the brain. That's the main role of the bicarb, but also can increase your urinary elimination. So urinary alkalization, I guess it can be categorized as here as elimination. Find the antidote. So fomepizole is your antidote, same as ethanol. We'll talk about that. So that's your first step is alcohol dehydrogenase. And then general management, I guess you can put cofactor here. So cofactors are listed here. So folate, folinic acid for methanol, pyridoxine, thiamine, and MEG is another cofactor for ethylene glycol, and we'll go through that in a little bit more detail next. So first, let's talk about alcohol dehydrogenase inhibitors. So this is the cornerstone of treatment in toxic alcohol. By blocking alcohol dehydrogenase, we prevent the metabolism of parent compounds, methanol or ethylene glycol, from being further metabolized and stopping the process here. So you can either give ethanol or fomepizole. Fomepizole is a little bit more expensive, quite a bit more expensive actually, but this is a preferred antidote because it has less side effect than ethanol in terms of things like hypoglycemia, less intensive nursing time demands. So we pretty much just use fomepizole here in Calgary. If you're in a rural place, you can use ethanol PO, so you can give them shots of vodka or whiskey to keep them safe while transporting them into a center that has fomepizole or hemodialysis. And that's what all I'm going to say. So indication for fomepizole or ethanol are so any end-organ injury and metabolic acidosis. For methanol, its level is 6. So this is converted from American units. So in America, units is 20, and for both ethylene glycol and methanol, this is an arbitrary number they just chose. But because ethylene glycol is larger, so it corresponds to a lower millimole per liter concentration. So greater than 6 for methanol, greater than 3 for ethylene glycol. And also, if you don't have the levels yet, because it can take a little while, if you have suspected ingestion with elevated osmolar gap greater than 10, pH less than 7.3, bicarb less than 20, 2 out of 3 here, you can start fomepizole. Ethylene glycol, if you have suspected ingestion with elevated osmol, low pH, low bicarb, or urine oxalate crystal, 2 out of 4, you can start. This is according to the ACT guideline. And here's the dosing for ethanol and fomepizole. Fomepizole basically 15 milligram per kilo bolus, and that will keep you safe for 12 hours. And after that, you give 10 milligram per kilo every 12 hours. And after 48 hours, because it induces self-metabolism, so you got to increase the dose to 15 per kilo every 12 hours. Ethanol, if we don't have IV anymore, I don't think, and PO, you give 3 or 4 shots, which should be enough to get your blood ethanol concentration to greater than 21. So that's the goal here. So greater than 21, you have about 100% blockage of your alcohol dehydrogenase. So be equivalent to fomepizole. And you need to read those every hour. Next, let's talk about bicarb. So the reason why we give bicarb if they're very acidotic is because, especially for methanol, formic acid is more toxic than formate. So if you're acidotic, you have more of the equation shifted this way if you're acidotic. So more formic acid, and this is unionized, so it can cross your lipid membrane more easily. Whereas this is formate is charged, so it doesn't cross very easily. So this formic acid will enter your brain, causes more toxicity, and also is more harder to clear urinally. So it's based on the concept of ion trapping, where the non-ionized form is easier to be eliminated and less entry into CNS. So that's why we give bicarb. Hemodialysis. So for people who are very sick, here, severe metabolic acidosis, any end organ injury again, vision, hemodynamics. They also talk about renal failure here from methanol, but that's a rare complication. Or if their concentration is greater than 15 millimole per liter, and this correlates to a 50 milligram per deciliter American unit. Same thing with ethylene glycol, basically severe acidosis, end organ injury like AKI, and ethylene glycol concentration greater than 8, which again correlates to American units of 50 milligram per deciliter. In terms of cofactors, there's been more evidence to support use of folinic acid in methanol than pyridoxine thiamine for ethylene glycol. So the reason why we give these cofactors is because of here. So formate can be metabolized by this enzyme 4-formyl tetrahydrofolate reductase, and it requires folate as a cofactor to be metabolized into CO2 and water. But it is probably not a significant amount, and clinical significance is questionable. Same thing here, where your with the metabolite glycoxylic acid is, instead of turning into oxalic acid, there's two minor pathways where it requires cofactor thiamine, pyridoxine, and magnesium to become ketoadipate, and glycine, hippuric acid. These are less toxic than oxalic acid. So that's the rationale for giving these cofactors. And the dose for these cofactors is higher than your usual for folate. So there's a high dose folate, 50 milligram IV instead of your standard 5 milligram for malnutrition, chronic alcohol patients. Pyridoxine 50 to 100 milligrams IV Q6, thiamine 100 IV Q6, and then make replace as needed. For treatment for isopropanol, so typically these patients will have pretty severe gastritis. Sometimes you can develop GI bleed, so you want to resuscitate for that. Give some GI protection with proton pump inhibitors. Basically treat them symptomatically. These patients will typically clear over time, but can take a little while. So they can be very inebriated, but they wouldn't be at risk for severe toxicity like methanol and ethylene glycol. So that's the end of this brief review. Hopefully this was useful, and please send any feedback my way in terms of if this is too detailed, not detailed enough, or anything I can do to make this more useful for you next time. Thank you for listening.